Good afternoon, everyone. My name is Amrit Kamboj, and I'm a member of the Cedars-Sinai motility team. Today, I will be talking about Clostridioides Difficile infection, diagnosis, and treatment. And thank you to the International Foundation for Gastrointestinal Disorders for having me here today. And equally important, thanks for all of you being here. I would like to disclose that I used several resources from the Centers for Disease Control and Prevention, or the CDC, for today's talk to reinforce some of the high-yield take-home points. The objectives for today's talk will be to provide a comprehensive review of Clostridioides difficile infection, including its epidemiology, clinical features, diagnosis, and treatment. So Clostridioides difficile, that's a handful, and the short name for this is C. diff, and that's what we will refer to for today's talk. This is what C. diff looks like. It's a spore and toxin-producing gram-positive anaerobic bacterium. And so that's kind of a handful, but it has the ability to generate spores that allow it to survive outside of the body for extended periods of time. And it produces two toxins, toxin A and B, that allow it to cause infection and symptoms. This commonly arises when the normal gut flora is disrupted, as in the case of antibiotics, which may be used for a urinary tract infection, pneumonia, skin infection. While the antibiotics are useful in treating that particular infection, they can also disrupt the gut microbiome, and harmful bacteria such as C. diff can take over the colon and cause infection. Several studies have been done on C. diff, and the most common other risk factors besides antibiotics for C. diff infection include advanced or older age, recent hospitalization, severe illness, conditions that weaken the immune system, and also inflammatory bowel disease like Crohn's disease or ulcerative colitis. I'll now take some time to outline why everyone in this room should care about C. diff. And for one, it's everywhere. It affects everyone, and it has the potential to affect everyone across the country or the world, in every state, and of all people of all ages. And it's estimated to cause almost 500,000 infections in the US each year. Reason number two is that C. diff is commonly not a one and done. In fact, 1 in 6 patients who get C. diff infection will get it again in the subsequent 2 to 8 weeks. If those are not enough reasons, here are some more. C. diff infection can be lethal. In fact, it accounts for 29,300 deaths annually. And specifically in our older population, those over age 65 years, 1 in 11 will die within 1 month of C. diff infection. Another reason to care about C. diff is that we discussed antibiotic use sometimes disrupts the gut microflora, and C. diff can arise as a result. And antibiotic use in today's community is common. And those with recent antibiotic use are more likely to have C. diff, maybe 7 to 10 times more likely. Now, not all C. diff infection causes trouble, and there is a concept, what we call colonization. This is when C. diff may be present within an individual, but it doesn't cause any symptoms. It's also known as the C. diff carrier state. Take, for example, the man in this image. If you do a stool sample, for example, you might see some C. diff organisms, but he otherwise feels fine and has no signs or symptoms, and this is what we call colonization with C. diff. In a carrier state, C. diff is kept in check by other bacteria, and as a result, doesn't cause any trouble. C. diff colonization is not uncommon and does not require treatment. C. diff colonization may occur after a recent C. diff infection that was appropriately treated with a course of antibiotics, but there may be some leftover small number of C. diff organisms. It may occur after a recent hospitalization. It may also occur in those with frequent antibiotic use and the disruption of the gut microbiome. And as a result, hand hygiene is very important for everyone to prevent acquiring C. diff infection and limiting its spread to other people. Now, the clinical presentation for C. diff infection can be quite variable. As we discussed, some individuals may not have any symptoms at all, such as those who are colonized with C. diff. But at the other extreme, people can be pretty sick from C. diff infection, and death can even result. The most common symptom with C. diff infection is watery diarrhea, and that can be mild, moderate, or severe to the point of causing dehydration. Typically, the diarrhea consists of watery stools that are not bloody. Other individuals may also experience abdominal pain, nausea, or vomiting. And in a subset of patients, fever may also be present. What are some complications of C. diff infection? In addition to causing diarrhea when there's severe infection present, there may also be inflammation or irritation of the colon that can result, and that is what we term colitis or inflammation of the colon. When this inflammation of the colon is even more severe, it can spread through the different layers of the colon, and it can actually affect the motility or the movement ability of the colon, and the colon can get paralyzed and be distended with air. And in some cases, when patients are critically ill, it may also cause rupture or what we call a perforation of the colon. In more severe cases, patients may also present with what we call sepsis, which is a chain reaction triggered in the body from an infection, where there can be high fevers, heart rate can be really high, blood pressure can be really low, the breathing rate can be really high, and sometimes patients with this presentation may require a level of care in the ICU. You might be wondering who to test for C. diff infection, and this is an individualized decision that is made between a discussion between the patient and their healthcare provider, but a general rule of thumb is that it may be reasonable to test for C. diff infection in those who have 3 or more stools per day, assuming that they're not taking a laxative or some other contributing factor. How do we diagnose C. diff? Stool tests are the mainstay for diagnosis of C. diff infection, and there's different varieties of stool tests. Some labs may use a PCR or a polymerase chain reaction, which looks at genes that are associated with toxic forms of C. diff. Other labs may use the antigen, which detects whether C. diff is present with or without toxin production. They may do a secondary test to check for those active toxins A and B. And a third test that's sometimes employed is a stool culture, but this can be cumbersome as it requires growth for several days in the lab. In addition to doing a stool test when there's suspicion for C. diff, it's also important to check some blood work. And the 2 main things to check for are the complete blood count, specifically looking at the white blood cell count, which can help determine the severity of infection, and also the creatinine blood test, which is a measure of the kidney function. Endoscopy is also sometimes performed in evaluation of C. diff infection, and I put an asterisk next to it because this is not required for diagnosis and should generally not be performed in everyone with C. diff infection. However, endoscopy may play a role in those with a severe presentation or where the diagnosis of C. diff is unclear or the stool test reveals an indeterminate result. To show you what we might find on endoscopy, this is an example of how the colon may appear normal. It kind of has a salmon-colored, pink-colored to it with vasculature that you can see the blood vessels very clearly. However, when there's inflammation or colitis that is occurring from C. diff infection, there can be redness throughout with some ulcers that can even be present. And the most severe form of C. diff infection that we sometimes see on endoscopy is something known as pseudomembranous colitis, where again, kind of the colon is very inflamed and irritated, and there can be white or yellow plaques that line the colon. Cross-sectional imaging, such as with a CT scan of the abdomen or pelvis, again, this has an asterisk because this is not required in everyone who has C. diff infection, but may be performed to evaluate for some of those complications that we discussed that can be seen with C. diff infection. Here are some images that highlight colon thickening or inflammation, and the arrows point to areas where the bowel wall is really thickened or swollen. Again, these images highlight the toxic megacolon, where the colon becomes paralyzed, full of air, and it can even rupture if left untreated for a long period of time. C. diff infection can be either mild to moderate, it can be severe, or it can be fulminant, which is a step above severe. Severe infection is usually defined by those abnormal blood tests. If the white blood cell count is elevated more than 15,000 and the creatinine or the kidney function number is elevated greater than 1.5, those are signs that a patient may be experiencing a severe C. diff. If endoscopy is performed, inflammation or the pseudomembranous colitis may be seen, and CT scan may show bowel wall thickening. Fulminant C. diff is a step above severe C. diff, and this usually requires presence of these things seen with severe C. diff, like the elevated white count and the creatinine numbers, but also presence of multi-organ failure where there can be hypotension or shock, low blood pressure, there can be ileus or slowing of the colon, or there can be that megacolon where the colon becomes very distended and full of air. Not all cases of chronic watery diarrhea are due to C. diff. And there are a list of conditions that can cause watery diarrhea, such as other infections, post-infectious irritable bowel syndrome or condition, celiac disease, microscopic colitis, inflammatory bowel disease are just a handful of other diagnoses that we think about in someone presenting with watery stools. I'll also highlight the concept of recurrent C. diff, which is defined as total resolution of symptoms, such as watery diarrhea, while on appropriate treatment for C. diff, but then once the treatment is stopped, there's a recurrence of symptoms just 2 to 8 weeks after completion of treatment. And as we had reviewed before, 1 in 6 individuals will get recurrent C. diff, so it's not a one and done for everyone. Risk factors for those who may get recurrent C. diff are older individuals, those with severe medical comorbidities, and those that need ongoing antibiotics while receiving C. diff treatment. And if you have a recurrence one time, it does increase your risk of getting recurrences again in the future. Now we'll shift to management and treatment of C. diff infection. And some principles regarding the management of C. diff infection in the hospital and even at home, everyone should follow what we call contact precautions. Everyone should clean their hands before entering and leaving the patient room or contacting with the patient. And usually we use hand soap and water rather than alcohol-based sanitizers because those by themselves are not sufficient to eradicate the spores that can be seen with C. diff. Providers may also wear gloves, gowns, use dedicated equipment. We should also scrutinize carefully whether the patient needs antibiotics because we know that using those can disrupt the gut microbiome. So if there's no need for ongoing antibiotic use, antibiotics should be discontinued. And those with severe watery diarrhea or dehydration may require IV fluids. Treatment for a first episode of C. diff, whether it be non-severe or severe, typically there's 2 medication options, and some of the common treatment regimens I'll highlight in my slides. So one option may be to use an antibiotic called fidaxomicin taken for 10 days, or alternatively, oral vancomycin may also be used taken for 10 days. Several years ago, kind of our go-to medication for treatment of C. diff infection was one called metronidazole or Flagyl, but studies over the last few years show that metronidazole may not work as effectively as fidaxomicin or vancomycin. So really, this is kind of only used now if the above treatments are not available. In cases with the fulminant disease of C. diff, where it's a step above severe, this is where IV fluids may really be needed. And because this can be even a life-threatening condition, we use a combination of 2 medications, IV metronidazole and oral vancomycin at a high dose taken together. And if the patient has ileus or slowing of the gut, rectal administration of vancomycin enemas may also be considered. What about if you have a recurrence or reoccurrence of symptoms 2 to 8 weeks after you had resolution of your symptoms with initial treatment? The key here is to use an alternative treatment than what was used before. So if the initial treatment consisted of the fidaxomicin or vancomycin or metronidazole, one step may be to consider what we call a prolonged vancomycin taper. Rather than a 10-day course of treatment, it might last for several weeks. How about in cases where vancomycin or metronidazole was used before? This is where fidaxomicin, something else, might play a role. Here are some common ways to use fidaxomicin: twice a day for 10 days, or twice a day for 5 days, and then once every other day for 20 days. That's the extent protocol. And then vancomycin, especially if there was initial response with a 10-day course, you might use a prolonged taper that lasts several weeks. Bezlotuximab is an IV monoclonal antibody infusion that has been shown to have some benefit in decreasing recurrence of C. diff, and this may be used in some cases where patients are high risk for recurrent infections. If you have a second recurrence, again, you can use an antibiotic treatment that you haven't used before, such as fidaxomicin or vancomycin. But once you kind of get the second recurrence, this is where fecal microbiota transplantation, or FMT, may play a role. And just to give you a little bit of background on this fecal microbiota transplantation, or FMT, this involves collecting stool from a healthy donor and instilling this in a patient with C. diff with the goal of restoring their gut microbiome. In this process, stool is collected and processed from a healthy donor and instilled into a patient with C. diff infection. Donors are carefully screened for medical conditions and infections. For C. diff treatment, FMT is greater than 90% effective, and it's most commonly currently administered via colonoscopy, but other methods have been studied and are being developed, such as use of oral capsules. Generally, it is well tolerated. Patient may present for a colonoscopy. They get the colonoscopy with the FMT. They go home the same day. There might be some self-limited abdominal discomfort that resolves within a few hours or days. And there is, despite the careful screening of the donors, there can be a rare risk of transmission of infection, although this is very rare. What can we do to prevent C. diff infection? And the key here is hand hygiene. We think the spread of C. diff happens by coming into contact with someone who might have C. diff infection or maybe colonized with C. diff, and then they forget to wash their hands, and they may eat something, and then they're kind of colonized with C. diff and may get the C. diff infection. So hand hygiene is really key here. I'll end my talk by sharing some of the frequently asked questions that I get in clinic regarding C. diff infection from my patients. After I have C. diff infection, when can I go back to work? And the key here is only once symptoms have stopped, because we want to decrease risk of spread to other individuals. Question 2, should I get retested after treatment? I heard Dr. Yin Chan's talk. He shared that for Helicobacter pylori treatment, everyone should be checked with a non-invasive test to make sure H. pylori is gone. Should I be doing the same thing for C. diff? Should I get retested after treatment? And the answer here is no, because you can have a few organisms left over, and it's kind of that carrier state, and that means that doesn't require any treatment if the patient's not having any persistent symptoms. Retesting should only be considered if symptoms persist or worsen despite treatment. What can I do to avoid getting C. diff again? And again, one of the take-home messages today is C. diff is not one and done. 1 in 6 will get recurrent C. diff. And so avoid antibiotics unless truly indicated. If antibiotics are necessary to get over a pneumonia or a urinary tract infection, then using the lowest dose or the lowest number of days of antibiotic use would be important. And inform your doctors that you've had C. diff infection, because that may affect their decision in how they treat you for your active medical problems. Hand hygiene, as we highlighted, is very important. And timely testing. If you start having the kind of the watery diarrhea abruptly, it's a sudden change, you had recent antibiotic use, getting tested and letting your healthcare provider know about that is very important to avoid those complications that we discussed with C. diff infection. At this time, there is an unclear role for use of probiotics for prevention of C. diff. There's not a lot of good evidence on that, and there's different probiotic regimens that are out there on the market, so our guidelines recommend that there's an unclear role for the probiotics. Here are my references, and thank you for your time and attention.